damage is limited to the first layer of skin. It will look very red. We've all had these from being out in the sun too much, and they are tender and painful. Partial thickness burn or second degree burn is superficial to partial thickness. You'll see big blisters. You'll see edema, which is swelling. They can be pain, and the skin is kind of moist with a shiny, shiny surface. Full thickness burn or third degree burn, it's damage, full thickness of the tissue. It'll be deep, it'll be red, it can look charred or white, kind of like charcoal bricks. It's usually painless due to nerve damage. This is a superficial first degree burn. The damage is limited to the epidermis. This is a partial thickness or second degree burn. It extends to the second major level of the skin. It blisters, edema, which means swelling, pain, shiny surface, wet, weeping, very high risk for infection as well as dehydration. The blister that you see on the bottom of the palm, we always caution people about, do not pop this, because this is nature's Band-Aids. If you pop it, you have opened up this wound to infection. Part of the reason we also worry about dehydration is that blister is filled with fluid. Depending on how big the burn is, you can dehydrate a patient very quickly. Full thickness or third degree burn. It extends through the first two layers of the skin, can even go into the fatty tissue. It's generally painless because of nerve damage. Very high risk for infection, and very high risk for infection, It's not always painless, just because if you look at the outside of the wound is going to be reddened or a second degree burn. So we need to take that all into account. And this, as I said, very high risk for infection. Of course, dehydration is a major complication as well. Lower extremity ulcers. Step back into your A&P class and realize that the arteries bring the blood down to the feet and up. The veins bring it back up from the feet to the heart with the lymph tissue. So arterial ulcers are caused by ischemia. Ischemia is a condition that's lack of blood. If it's easier to remember, a myocardial infarction is an ischemic attack on the heart. Diabetic, it's caused by trauma or pressure. A good deal of the diabetic ulcers we see are on patients' feet due to the fact that part of diabetes gives them a condition of neuropathy, which means they don't have the nerves to feel trauma or pressure. Pressure, it's caused by ischemia, lack of blood flow from pressure. Venous ulcers are caused by edema, that swelling of the skin, and impaired venous return. There is, in the back of the leg, two gastrocs muscles, and there are little pumps in the veins that open and close like a bridge. What happens is, as people have venous problems, these little valves just start fluttering around and don't open and close on a regular basis, and that's what causes the swelling and the edema in the legs. Arterial ulcer. You will see that the skin is very, very shiny. They're usually rounded out edges, and as you can tell on this slide, that the edges of the wound bed are curled around. No hair on the skin, and that's because the body is such a fine-tuned machine that it is not going to waste blood to put hair on something. It's going to get the blood going to the area that needs it to be able to heal a wound. Now, the skin may be very cool to the touch, and you'll notice that on a lot of patients where they have cold toes, and that is arterial insufficiency. You'll usually, we double check for your pulses, and it will be diminished, or sometimes they are totally absent. They're usually located around the toes, lateral malleolus, which is the ankle bone, and areas that are subject to trauma or rubbing of footwear. These are very typical diabetic neuropathic ulcers. As you will see, they are located over what is called the metatarsal head. And what is caused is the toe will start to cock up, and it's called a hammer toe, and the metatarsal head starts poking down on the plantar surface of the foot. So what you're seeing here is around the edges is a huge callus formation, and you're seeing the wound in the middle. But the problem with the callus is it does not allow blood supply in to heal the wound. These are super high risk for infection. Patients with diabetic ulcers generally end up with amputations, unfortunately. So this is pressure ulcers, and it's pressure ulcers of the heel. On the left side of the screen is what's called an unstable eschar. As you can see, we've got some granulation tissue, or that little pink tissue around the eschar. On the right-hand side, this is a stable eschar. We suggest avoiding, if you don't know what you're doing, avoiding removing these, because the fact these are areas where you've got bone right under the surface. And when you expose a bone to air, it is automatically considered osteomyelitis. Osteomyelitis is an infection of the bone. Sometimes they handle it with amputation. Since I work in infectious disease, we have always done IV antibiotics, but it's a long stint. These patients have to go through a good 6 weeks of IV antibiotics. So we suggest very strongly, do not remove them. This is your venous ulcer. Very common because the venous return, you cannot get the blood flow back up in the lymph. You'll see that they have a real jagged edges, in contrast from the arterial ulcer that was round to the end, around it. They're very superficial. We call it ruddy granular tissue, or kind of looks like ground beef. Usually are painless, but if they're just deep enough that you're getting to a superficial nerve, they are very painful. Heavy exudate. Exudate is kind of wound juice. It is the lymph. It could be infection. But they can put out a vast amount of fluid. The standard of care for compression is compression therapy, meaning Una boots, the TED hose, that kind of thing. But these need to be placed by licensed professional. Stage 1 pressure injury. The skin is intact, meaning there's no open wound. It persists with redness, and it's non-blanchable. What this means is if you put your finger on it and take your finger off, it doesn't go to white and then back to red. It just stays on red. Skin temperature usually warm, or sometimes if you're cutting off enough of the circulation, it's going to be cool. It can feel firm, it can feel boggy, which is kind of squishy and mushy. Stage 2 pressure injury, partial thickness wound loss with exposure down to the dermis. It can look like a blister and an abrasion, but it is just an open wound. Stage 3, it's full thickness loss. It can go down to the adipose tissue. It can go to bone. And what we know is bone, open bone equals osteomyelitis. It talks about a deep crater with or without undermining. What undermining is on the wound bed edges, you can take a Q-tip and run it underneath. So it's almost like you've got an open wound on top, but it extends under the skin layer. Stage 4 pressure injury, full thickness loss, may extend to the bone. Undermining, which we discussed. Sinus tracts, all those are is little round tubes of skin that may track off into different areas. Unstable or unstageable ulcer. You cannot determine the depth of an ulcer when it's unstageable. It may have slough, which is this white kind of protein or yellow kind of protein buildup, or it may have the eschar. Best way to describe an eschar is it's kind of like a piece of beef jerky, very, very hardened, but we have no idea what's underneath there. Most likely we have bone, but we cannot state that because we don't know for sure. Deep tissue injuries. Deep tissue injuries will present, like the picture on the right, as a deep hematoma. This is over a bony prominence, your calcaneus. So what has happened is blood has pooled there. They're found very commonly on the heels, the sacrums, offloading. The pressure helps to keep the skin intact. This is another one of those, do not open this up. This is nature's bandage. The skin will reabsorb, or the skin will reabsorb the blood clot. You open it up, you are opening yourself up to infection. Medical-related pressure injury. Medical device-related pressure injury, sorry. This is caused from devices used for therapeutic or diagnostic procedures. This wound on the ear was actually caused by a nasal cannula for oxygen. Woman had it over her ear, laid on the side of her head, and there you are with an open wound. And that is actually cartilage you're seeing at the bottom of this. It usually takes the shape of the device, and this is very common. Mucous membrane injury. This is found, of course, in the mucous membranes. With the hair, it does have a history of medical device use in this area as well. This was actually caused from a suction at a dentist's office. It can't be staged because of the location. We don't know how deep that runs. So pressure injury causes. The lack of blood flow, which is ischemia, very poor nutrition, dehydration, friction, shear, sustained pressure. One thing to remember is, and the hospitals have, as of, I think it was about 4 years ago, they changed up their habit of patients in the ED on gurneys, that they need to rotate the patient or provide some support to the heels after 45 minutes because those injuries, they're showing the stage 1 pressure injuries. You'll see pressure injuries a lot in the elderly just because of the fact that elderly people in nursing homes don't have the best nutrition. As we age, all of our skin ages. And some of them, it's very difficult to eat everything they see on the plate because it's so much food. You will also notice with the elderly is dehydration. It's a very important thing. I would constantly talk to Mom about it because I'd say, "Are you drinking your water?" And she'd say, "Oh, yes." And then she'd reach for her glass of water. Well-hydrated cells are one of the key things to be able to heal a wound, as well as a good level of protein. Friction is a little different from shear. Friction is if you took a patient and their back was open and you just pulled them up on a bed. That is a friction injury because what you're doing is dragging everything over that bony prominence. Shear is when you have a patient that you are trying to lift, but one area is staying secure on the bed and the other area is separating from it. Skin tears. Skin tears, as I talked about, as we age, every tissue ages. You will find that in the elderly, especially on their skin, hands, they get skin tears. They just knock up against something and it just tears off the skin. Also, thing to remember as well is as we age, even something as simple as our bowels, that tissue is aging as well. And that's why very cautious of elderly people and when they're doing colonoscopies and things like that. Very, very high risk for infection. Unfortunately, with these, the elderly don't normally have the hand hygiene that most other people do, and as we are now having to find ourselves in COVID doing, the best way to take care of these is protect it, keep it moist. Use a non-adherent dressing just because of the fact if you dry out a wound and you have a gauze on it, you're going to rip this off when you change the dressing. I really suggest staying away from Coban just because it can roll up and you'll lose your base membrane that you're trying to protect. As well as, good rule of thumb is on any of these, avoid using staples on a wound with the elderly because of the fact that the staples will just tear through the skin versus using suture, which will allow the edges to adhere to each other. So we individualize our goals for our patients. We know everything there is to know about wounds, but the one thing to remember is just as every patient has their own personality, so does every wound. Wound care is not going to the cupboard and saying, this looks like a good bandage to use today. I think I'll try that. It's knowing we need to balance between dry and moist for wound healing. Now, the phases of wound healing are, the first one is the inflammatory phase. It begins at the time of injury, lasting 4 to 6 days. So you run, you fall down, you skin your knee, that is the inflammatory stage. You get it cleaned up, and at that time, hemostasis begins. All of the good cells, the macrophages, the protein, they come to the wound to start rebuilding, regenerating. The proliferative phase is with granulation tissue. It can last between 4 and 24 days. When we get into a chronic wound, what happens is the wound gets stuck in that proliferative phase. where it's just generating tissues, but it's not really healing. It's just running a little race in the wound. The maturation phase is when the collagen fibers come in, they mature, they gain their strength, they remodel, and a scar is formed. One thing to remember, scar tissue is only approximately 80% as strong as the original tissue. And that is 1 year down the road. So take a step back, think about a venous stasis ulcer. You have the venous stasis ulcer. We've finally been able to get it healed. It's got tissue over the top of it, but if your patient does not adhere to compression, wearing the TED hose, anything like that, the minute that leg begins to swell again, the fluid is going to go to the least place of resistance, which is going to be the scar tissue, and it's going to open up and pour out again. Myths about wound healing. I know we've all been told, leave it open to the air to dry it up, it'll heal faster. That's wrong. Actually, wounds heal 3 to 4 times faster and are less painful in a moist environment. Stepping back again, but you have to think about that venous stasis ulcer is moist wounds heal, dry wounds do not, but overly moist wounds will not heal as well. And I know many of us have done this. Clean the wound with hydrogen peroxide or betadine. Hydrogen peroxide and betadine destroy the epidermis and dermis cells. You can see the hydrogen peroxide destroying cells as it bubbles on a fresh wound. So being gentle with these is very, very important. Cleaning well, but using the right pump. I'm always asked about MRSA or methicillin-resistant Staph aureus. And I like to stress that, should you be frightened of it? No. Should you be frightened of Pseudomonas, E. coli, C. diff? No. Methicillin-resistant Staph aureus is just a staph that is resistant to the penicillins. There are other medications to do that, but the most important thing to remember is to make sure you wash your hands and glove up. Culturing a wound. There are generally 2 types of cultures that are acceptable. The first one is a Z-stroke, and what you basically do is hit different points across a wound. It's usually a 10-point sweep. The Lymphine method, what you do is you take your cotton swab or your alginate swab, press it right into the middle of the wound and kind of spin it around. This one really is the technique that I use. I like it a lot better because you have to have a clean wound, and sometimes with a Z-stroke, you will pick up some just slough for necrotic tissue. Always use the calcium alginate or rayon swabs. This is my Da Vinci. So now we've got a big picture about wounds and how to treat them and what are the shortcomings and everything. How do we find out what kind of dressing to use? There are many different types of dressings. Number 1 is alginate. It's actually calcium alginate. If the name kind of seems familiar to you, it is basically formed out of algae, but it's clean algae. It facilitates autolytic debridement, which means allows the body to debride, to get the slough, the decaying matter away. Pardon me. It can absorb up to 20 times its weight. It can dehydrate a wound. So we're stepping back one more time to Moist wounds heal, dry wounds do not. So if you dehydrate a wound, what you're going to do is bring us back to square one on how do we heal it. It can be impregnated with silver. The one on the left-hand corner, that is what's called meta-honey calcium alginate. And meta-honey is this wonderful medical-grade honey that, pardon me, is produced in New Zealand, and it really helps to debride a wound. Actually, silver as well, just a quick reminder on that, silver is an antimicrobial, and it's nice to use on any type of, that you may think that you have a little bit of infection going on. So I can get a drink. Bye-bye. Collagens. Collagens are the building block of tissue. Collagen comes in many different forms in the dressings. They maintain a moist environment, which we've discussed is appropriate and good for wound healing. One thing to remember on all of these dressings is read the package insert. Not a lot of them are recommended for full thickness burns, or it makes no sense to put a collagen on a eschar because it's beef jerky and it won't absorb the wound. So collagen, it makes your skin moist and supple, but collagen is a protein. So then we take it back to the picture of the burns. Kneading, that's when we up the protein in a diet if it's feasible, just because of the fact that it adds more protein to the body, helps with collagen formation and healing the wound. Foam dressings, they come in all shapes and forms. What they do is generally with a prescription grade foam dressing, it will take the foam dressings, what they will do is they will absorb the exudate, and generally they disperse it off to the side so you're not sitting on a pool of fluid in the middle of that wound. They can absorb so much fluid, it's unbelievable. Many of them you can use under compression. They come in all shapes and sizes, which is an important thing to remember. The ones on the lower right, you'll see that there's circular dressing. Not all body parts are flat. Think about your elbows, think about your knees. It's wonderful to have in your arsenal of foam dressings a round dressing. Absorbent. These come in many different shapes and sizes. They're usually have the little kind of gel absorbing round beads in them, like in a diaper. They are highly absorbent. It reduces the risk of maceration of a wound. And what maceration is, the best way to describe it is if you've spent too much time in the swimming pool, hot tub, something like that, your skin turns all white and kind of wrinkly. That's maceration. It does not contain the odor, though, just because it just absorbs the the exudate, but the exudate could be smelly. It's a low risk for leakage. One thing to remember on this is I had a home care nurse that we were using one of these dressings on, and she didn't have the right size, so she cut it in half. Those little balls came out and were dropped into the wound bed and were caustic to the wound. So need to use products the way they were meant to be. Barriers. Barriers are a very important product that we have in our arsenal. They provide protection, from body fluids, such as, and I know sometimes we have people that are incontinent. Feces, urine is very acidic, caustic to the skin. You will see burns from stool. Good deal of times when we have patients that have had a ostomy placed, you will have to protect around the outside of it so we do not have any stool that's getting on good skin. I like the one on the Cavalon durable barrier cream. It's not as pasty as most, and you can go ahead and apply tape to it and after you put the durable barrier cream on. Hydrogels. We use these to rehydrate wounds. They're highly recommended for radiation burns. Good deal of cancer patients, status post mastectomy, things like that. You will get a burn, and this will calm things down. They can contain silver, they can contain collagen. I tend to stay away from things like the Amerigel because that contains an oak resin in it. And if you have somebody that is allergic to something and has hay fever, those kind of things, want to stay away from that. One note on finding out about, on a side note, I'm finding out about allergies is I had years ago this wonderful German woman who was an ex-stewardess. She had a venous stasis ulcer on her lower leg, and I could not get it to heal. We'd gotten the exudate under control. She was wearing compression, but it just wouldn't heal. And the one day she came in and she had a beautiful, beautiful Black Hills Gold cross on. And I said to her, "Oh, what a lovely cross this is." And she said, "That was the last thing my husband gave me before he passed on. I can only wear it when I wear turtlenecks." The next word out of my mouth was, "Do you have a metal allergy?" And she says, "Oh, yes." Took the silver out of the collagen that I was using on her, and she closed up within a week. So that's one thing you always need to remember is think outside the box, ask all the questions. Compression wraps. This is what's called an Uniboot. As we discussed, compression promotes venous return, prevents the blood from staying down in the foot, decreases edema, and it enhances those little bridge valves to open up and allow the fluid to come back to the heart. They cannot absorb a lot of fluid. So you do need to use a secondary dressing on it, either a foam dressing or something different. Peri-wound, that is the outside of your wound, may become macerated. That's the being in the hot tub too long, white skin around the outside. They're indicated for venous stasis ulcer management and lower vascular disease. Big thing to remember is you don't apply these to arterial ulcers. And the reason being with that is the arteries, if you have compression, so you're compressing from just beneath the toes up the ankle to right below the knee. If you use it on arterial insufficiency, what you've done is you've stopped the blood flow coming below the knee and down. You wrap from just below the toes to the tibial plateau, making sure that you include the heel. Reason for this is because if you are compressing from the toes and you stop at the heel and it's hanging out, and then you compress on up, you have given yourself a break in the compression that's going on, and you've also set yourself up for a possible pressure injury of that ankle. Don't have wrinkles in it just because of the fact that you're applying pressure from the outside and the type of Coban wrap you're using, and you can cause a pressure injury underneath. Don't use on patients with acute CHF, which is congestive heart failure, that stems right with our arterial insufficiency. And make sure you do not apply too much Coban with too much of a tension. The Coban is what gives us the venous flow back up, but you can also stop that flow if it's too tight. Maggot therapy. I'm always asked about maggot therapy, and these are wonderful, wonderful little beings that we have in our arsenal. Maggots are a form of debridement. We get medical grade maggots from a company that's called Monarch Labs. It's in California, and they propagate these maggots and send them in a little jar like that. And what you do is they start out life about the size of an eyelash. By the time they have done their job on a wound, they're about the size of a piece of rice. The picture on the below is what's called a cage dressing. So what we do is we take these little eyelash things, and depending on the size of the wound, you'll use 500 of the larvae. You may even use 1,000. Then you build this cage dressing. As you can tell, they need to be able to have an open ventilation thing. We'll put foam dressings on top to get all the the exudate. And we keep this on for a period of 48 hours. What these maggots do is they know only to eat infected tissue. They do not harm any of the good tissue. Once you come in and take off the cage dressing, you take all the little fat maggots and put them into a biohazard, because they are now biohazard material. As I said, these are such a wonderful tool to have. I've had people say to me, oh, how you can't stand the idea of having a maggot on. Well, if you're looking at either getting this wound cleaned up so we can put maybe a skin graft on, or doing an amputation, people will put up with about anything for 48 hours to avoid having an amputation. Total contact casting. What this does, and we use this a great deal on our diabetic ulcers. Our diabetics have the plantar surface ulcers, and they have that callus around the outside. And the best way to get the blood supply to the ulcer to go ahead and get it to heal is to offload the pressure. So basically you have them in a cast. This is changed out weekly, and there is an area around the ulcer that is opened up so you are not walking directly on that ulcer. Negative pressure, a good deal of you will know this as wound vacs. But negative pressure, what this does is it helps the wounds. It's a machine that we put on using foam onto an open wound. It helps the wounds to heal from the bottom out, outside in. It removes exudate and infectious materials. It evenly distributes negative pressure. It's 125 millimeters of mercury, which is the standardized. And I've seen wounds, it seems like literally heal within weeks of something that had been there for a long, long time. Wonderful thing. One thing to remember about negative pressure when doing the foam application is, as we discussed, these wounds products do not know anything but this is my action, this is how I do things, and this foam knows, okay, I need to suck this up, but the thing to remember is it doesn't know good tissue from bad. So if you put that foam dressing on regular, good, healthy skin, you will basically destroy it. So now we've come to the fun part of it. I know you know everything there is to know about wounds. Let's double check you. Okay, let me give you a hint. It's got irregular edges. Looks kind of like ground beef in the middle there. Yep, you're right. It's a venous stasis ulcer. Let's give you a hint. Never remove from the heel or sacrum or base of the skull. You're right again, eschar. And we don't remove them from that area because these are areas that are so close to bone, and exposed bone does equal osteomyelitis. You're right on that. Good job. Also, remember, this is one we will also up protein to help with the collagen rebuilding of the skin and keep that blister intact. You were listening. Good job. And remember, the reason we don't have hair on arterial insufficiency is because of the body being such a well-tuned machine. It's not going to supply blood flow to an area that isn't critical. You are right again. And yes, the elderly are at a high risk for infection on this, but as well as any other patient, always think about open wound is at high risk for bacterial growth. Yes, that's a diabetic neuropathic ulcer. Two of them, actually the leg on the foot on the left-hand side is what is termed as a Charcot foot joint. In diabetics, they have a problem where the whole midfoot collapses down. You can see how wide it is. And you have, it's almost like a rocker bottom on the bottom there. And that's why appropriate shoes, offloading things are so important for your diabetic. Also, check out both feet on this. We're missing some toes there, and they had to be amputated because of infection. Any questions? Well, I thank you very much for your time. appreciated chatting with you today. You all take care.
Thank you. That was very interesting.
All right. Let me. Okay. So Amy's always great. She also came in and we shot a couple of videos of the application of the Uniboot. So I will play that in the next little session. But why don't we take a break? Why don't we take about a 10-minute break? I know after all of those amazing pictures, you all want a snack. So, so go get some tea or coffee or a snack, and I will. I'll set up the next portion. We'll also take a little attendance quiz when y'all come back.
Okay, sounds good. See you in a little bit.
Okay, sounds good. Thank you.
10-4.
I have a little poll. So I'm going to launch that. Okay, so you should see the poll question. This way we'll make sure everybody's back. Almost everybody. Okay. Anybody else before I end the poll?
There was only one question, right?
That's right.
Okay.
I tried to keep them short this time. Okay, I'm going to end that one. So the answer was dead tissue. They only eat dead things, which is nice for wound cleanup. And Nicole asked a question about everybody's desire to continue their education. It's in the chat area, or you can just share now. Is anybody doing anything additional, getting some additional certifications besides Richard?
I'm getting my degree in health sciences, and it seems to be pretty cool and just super well-rounded, so that's why I ask.
Nice. Is that a associate, a bachelor's?
It'll be a bachelor's degree. It actually worked out really well with medical assisting. I got over 2 years of my credits done because I got an associate's in medical assisting, so it was super, super nice.
Nice to get half of your credits already accounted for.
Where are you going to school, Nicole?
Southern New Hampshire University. I love their program because they're all year round, and you get little breaks here and there, and it is probably the easiest thing, sorry to say, but that I've ever done. I mean, it was easier than medical assisting school, so that's for sure. It's 8-week classes, and I'll finish, because I'm going part-time, I'll finish August of 22, so the same time my sister graduates high school. That's how I know I'm almost done.
Wow, that's amazing. Yeah, it sounds like an interesting degree.
Yeah, I mean, it pretty much covers everything. And one of the classes I can get 15 CEUs for my AAMA, which is awesome.
That is amazing. Yes. Let's see. Jen is a farm tech. That's nice because that does allow you to work some interesting hours, a little bit more versatile. And Kimberly is doing her nursing prereqs. And Richard and I decided that we wanted to do public health. So we're both doing a public health program, Masters of Public Health. His is from New Mexico State University and mine is from Purdue. So I'll be done in May with a master's. I don't know why I thought I needed another degree, but I think it's all part of getting an associate in public health at Front Range. So we're working on that program.
You're so awesome.
I like to punish myself.
Well, how many degrees do you have now?
3 degrees, and I can't even count the certifications.
Let me catch up to you. I need some.
Absolutely.
You have time for everything.
I
Yeah,
know.
how do
I'm a
you
little
have
overwhelmed
time?
right now, that's for sure. I was a little bored during quarantine. That's what. All right, so I'm gonna share my screen here. Oh, you know what? Let me go back. I have to make sure. Yep, share computer sound. All right, so this presentation has more videos in it. Carol and I shot some real high quality stuff. It was fun. It's always fun to see Carol in action. All right, so let me just start this. Okay, I'm gonna shut my video off. All right, so I shut my video off. All right, so usually when Amy does the information about wound care, she brings this big giant box full of stuff that is all of the samples of of wound types, and she also brings items to let you touch and play with, and so her presentation usually does take 2.5, sometimes 3 hours. So it's really interesting not to have her talk you through every single wound applicant. So there's a lot of interesting stuff that she did bring. And we'll see at the end of this PowerPoint presentation, we'll see her apply the Una boot in a couple of different ways. So something that she didn't touch a lot on is the different types of exudate. I mean, she mentioned exudate, but there are several different types of exudate. So when we see exudate, we know that this is a byproduct of vasodilation, and it's occurring during the inflammatory stage. So we can tell what's going on when we assess and evaluate the drainage. So the first type is serous. So serous contains serum, which is that clear portion of blood. So it has a watery or clear appearance. So I tried to get some images that displayed that. Sanguinous, sanguino means related to blood. So this does contain red blood cells, results from capillary damage. We often see this in open wounds. Serosanguinous contains blood and serum. We often see these types of exudate in surgical incisions. Purulent contains pus. So we have pus, which is leukocytes, dead liquefied tissue debris, dead and living bacteria. This is typically going to present as thick yellow. There might be some pink or green. Oftentimes it can be gray or tan. It depends on what organism has infected the wound. There usually is an odor as well, indicating that there is an infection. Suppuration, or to have a suppurative drainage. Suppuration is the process of pus formation. So it is a verb. Purosanguinous exudate is pus and blood. This indicates a new wound that is infected. And when we're documenting wound drainage, we evaluate or assess and document the amount. So copious, large, medium is a moderate amount, scant, very small amount on the wound barrier. And you can quantify it by notating the amount on the size of the dressing. So like the first one, that might be a 2-inch diameter versus the third one where the entire 4x4 dressing is saturated. Now the different types of dressing. So dressing, bandage, we commonly use those terms interchangeably. The term dressing actually refers more correctly to the primary layer that's in contact with the wound, where a bandage is a piece of material used either to cover the wound or to keep the dressing in place, to apply pressure to control bleeding, or to support some type of medical device like a splint. So we're going to use dressings directly over a wound. Dressings are sterile. They cover and protect the wound from contamination. They also are responsible for absorbing all of that exudates. Any of the drainage, blood, serum, or pus is going to be collected in the dressing. It exerts pressure over an open wound. It can control bleeding. It hides disfigurement during healing, and it can hold medication against the wound also to help facilitate healing. Bandages, primary purpose there is to apply pressure for controlling bleeding, protect it from contamination. If we need to hold the dressing in place, the bandage will help do that. And to protect, support, and immobilize a body part. So in the videos, Carol uses a couple of different types of dressings and bandages to hold those items in place. And she'll kind of go over some of these bandage guidelines, but I just want to reiterate them now. So you're always going to want to follow the manufacturer's instructions when you're applying dressings and bandages. Use medical asepsis. You want to remove the jewelry promptly at the time of injury because you definitely don't want to have to go through that process of cutting somebody's ring off or cutting somebody's bracelet or any other apparatus that might cause constriction. You want to make sure that that comes off first before the inflammatory response has time to fully engorge and potentially cause an additional injury. So removing jewelry at the time of injury is really important. The area should be clean and dry and free from debris. Any open wound should have sterile dressing applied first. To prevent irritation, the skin surfaces of two parts should not touch. You want the pad between those two surfaces. And then Carol's going to talk about CMS several times as she's doing the wrappings. So CMS is an assessment check, and we're going to check for capillary refill, so circulation. For the M is motion. The person should be able to move whatever part has been injured or below the part where you're applying the dressing. And sensation, again, they should have tactile sense. You want to make sure that your application of the dressing is not cutting off nerve supply. So you want to make sure that they don't have any numbness or tingling, except that sensation loss that's due to swelling. There might be some sensation changes due to the inflammatory process. All right, here's your CMS check. So again, you're just applying a little bit of pressure. If we're going to put a bandage or a dressing on the forearm or at the elbow or anywhere near the hand, we want to apply pressure to the fingertips and hold for a few seconds. And we're looking for or waiting for capillary refill. So less than 3 seconds. I mean, you can do that to yourself right now, unless you have. It's a little bit harder to see if you have nail polish on or fake fingernails on. So less than 3 seconds is normal, 3 to 5 seconds is delayed. This technically would require some type of action. More than 5 seconds is considered sluggish, and it does indicate compromise, impaired circulation, also requiring action. You might need to undo your dressing and evaluate a little bit further and not apply the compression so tightly. M is motion. So as soon as, for instance, in that picture, as soon as we get that ACE bandage on there, we want to make sure that the person can wiggle their toes, that they do still have motion. If we need a particular area to be immobilized for the healing process, then most likely we are going to put them in some type of a boot or a sling, something that will prevent the patient from moving. It's kind of like a cone, right? The cone of shame. And S is for sensation. So we want to make sure that they don't have any of that numbness or tingling that is exacerbated by the application of the dressing. All right, so this is Carol, and she popped in for a few minutes. I don't know if she might be able to return, but so this is just her introduction to dressings.
Welcome to bandaging and wound care. I'm going to focus on bandaging, Bandaging uses medical asepsis, which prevents microbes from spreading from patients and providers. Dressings focus with sterile techniques, sterile asepsis. Welcome to bandaging and wound care. I'm going to focus on areas should be free of debris, dry and clean. Any open wounds would have a sterile dressing on first. Bandaging prevents irritation between two skin surfaces. Watch for signs of tightness. CMS checks. Assess temperature of extremity. C is for capillary refill. Once the bandage is put on, press the toes or fingers and they should pink up in 3 seconds or less. That's normal circulation. 3 to 5 seconds is delayed, and greater than 5 seconds is sluggish, and that indicates compromised, impaired circulation. Motion, the M, ask your patient to move or wiggle their fingers or toes, and assess their sensation. Assess for numbing, tingling. Some of that is expected during the swelling. Areas should be free.
All right. So I didn't realize how soft it was as far as her voice projecting. I hope y'all can hear it okay. All right, so the first bandaging technique that we have in the video is circular. We're actually going to cover circular and spiral together. So circular is often used to anchor and secure the bandage when it's started and when we end the bandaging process. It's applied to an area with uniform width, such as the head, the toes, the fingers. We want to use 2 circular terms to anchor the bandage and then begin and end at the other end of the bandage term. So let's look at spiral. So spiral is very similar. Spiral partly overlaps the previous term. So the overlapping varies from a half of the bandage width to 3/4 of the bandage width. We want to apply this to a body part with fairly uniform circumference, but is carried upward with the current wrap overlapping the previous turn. So fingers, arms, legs, the chest, the abdomen. You can use spiral turns on those body parts.
I'm going to start with the circular wrap. This is used to anchor and secure each bandage. It will start and end each one. We'll put it at an angle and wrap around. And I will continue to wrap, going about a half of the bandage width each time. It goes into a circle. Newer have Velcro, some of them have little staple type apparatus. What I want to remind you about that is if you use tape to tape this, always tape only on the bandage, not on the skin. Okay. If they're able to reuse the bandage, as you're taking it off, re-roll it. It'll save you some time make it easier to reapply once the dressing has been changed. Demonstrate a spiral. And again, we're going to start with that circular anchoring turn. And this angles up about 50 to 3/4% of the width of the bandage. Again, I'm not pulling it as tight as I could, but I'm pulling it what I call 50% tight. And usually I end with a circular turn, Velcro. I'll ask the patient how that feels. We'll assess their circulation, pressing on each finger, ask them to move their finger, and how does it feel? Okay. I'm going to start with the circular.
All right, next is the spiral reverse. This one's really interesting, and it took me a while to actually get it right. So you have to have some dexterity, and sometimes it's hard to get the wrap to cooperate with you when you're doing the reverse turn over your fingers. So typically we're going to use the spiral reverse when we have body parts that are of various width. You know, some men might have big forearms, well, some women too, but where you have a little wrist and your forearms continually gradually get bigger. The spiral reverse will help keep that tension and the wrap uniform. Same with lower legs, you know, skinny ankles and then bigger calves.
In the spiral reverse, this is a modification of the spiral. And this bandage technique is very useful when there's various widths between, say, the wrist and the forearm or the ankle and the calf. It fits nicely. I'm going to again start with that circular turn, that anchoring turn. Now start my spiral. This time I'm going to reverse it. 2 fingers there. And complete this with the circular turn. Again, ask your patient if they can move the CMS check, if they can move their fingers or the extremity of the toes. I will compress each one to see that the circulation, that they pink, that returns pink within less than about 3 seconds, and ask them how it's feeling. If they're feeling numbness, tingling, some of that may be due to the injury, but I always can rewrap the bandage as needed. Straighten the spiral.
Now the figure 8 turn we're typically going to use at a joint that needs to be able to flex and extend. We want to be careful here because of the again, the tension that you can put on an area and still allow it to move. I've put on a few figure eight wraps for ankles and elbows. A lot of the taping that I do in my office is actually with kinesio tape. That's not necessarily for a wound, but for soft tissue injury that's maybe internal, like a ligament sprain or tear. And so kinesio tape allows the body to be supported and still function. Where a lot of times with if you're doing really stiff athletic tape type figure eight turns, that's for no movement. The ankle is not going to be able to move. Now, if using an ACE bandage is again a little bit different. There's still an opportunity to move that particular area.
Demonstrate a figure eight wrap, and generally we want the limb flexed in a natural position. This is often used on a sprained ankle. You can demonstrate it here on a toddler elbow. Starting with that circular turn that will anchor this bandage. Go around a couple of times. And then, as the name implies, a figure eight. And the elbow is flexed. Go around. And complete that with the circular turn. And it allows for movement. Assess that the capillary refill is intact, that the client can move the lower part of the extremity and the elbow, and secure it with tape, and again inquire with them if how is it feeling for them. Thank you. Demonstrate a figure eight wrap.
Oops.
And
this bandaging, oh my goodness, very difficult. It was really difficult for me when I was trying to practice this. So the recurrent turn is a series of back and forth turns used for fingers, the head, or amputated stumps. You anchor the bandage with 2 circular turns, and then you pass back and forth over the tip of the area when you begin to bandage it. So it actually is interesting that this this can stay on the head or amputated stump.
I'm going to demonstrate a recurrent turn. It's a series of back and forth turns used on fingers, heads, amputated areas of the body. It starts with the circular turn. And that anchors that down. Recurrent turn, go back and over, and then end with the circular turn. cut. I need to go back and forth more times. Take that.
It's definitely different on a real person with hair.
That's what these look like. Have you been glued to the new? I'm going to demonstrate.
Now, tubular gauze, this is really interesting. The cages that are available for wrapping, usually fingers, toes. It could be used for the arm, as you can see here, the arm or leg, and even the head. The elastic gauze that you can purchase or that is associated with the cages like this they're kind of like a sleeve. The gauze isn't sterile though, so you would you can only use these as anchor dressings.
Tubular gauze bandage is a specialized elastic gauze that resembles a sleeve. It's usually used for fingers, toes, arms, legs. The gauze is not sterile, and it is therefore used to anchor a sterile dressing in place. The procedure, it requires the use of a frame. See, the frames are different sizes here. Would be like for an adult arm. This could be adult fingers or toes. The gauze is applied over the frame and then it's cut, and it starts like this. Twist only at the end. Down. Actually got 2 layers. Then tied and anchored that. This requires some training. I want to remind people not to tie it here at the end of the digit. It's appropriate to tie it around the wrist. Helps it stay on. A reminder, be trained in the proper application and the possible complications with this. Avoid using in patient at risk with morbidities as COPD, diabetes, peripheral vascular disease. Again, remind you to look at the manufacturer's instructions and directions before applying. It's a nice tool to have though in our bandage for bandages. Tubular gauze bandage.
Now the spica turn is interesting. So I found this video. Carol didn't demo this one, but I found this one really
The
interesting.
basic thumb spica technique is a figure of 8 pattern encircling the wrist and thumb. This technique provides mild to moderate support and lessens excessive range of motion of the metacarpophalangeal or MCP joint when preventing and treating thumb sprains and post-dislocation and post-fracture injuries. You'll need 1-inch non-elastic and elastic tape and 1.5-inch non-elastic tape for this technique. Pre-wrap or self-adherent wrap may also be needed. Position the individual sitting on a taping table or bench with the hand and thumb in a neutral position. You may apply the basic thumb spica directly to the skin, or apply 2 to 3 layers of pre-wrap or self-adherent wrap with the basic spica technique. Anchor a strip of 1-inch non-elastic or elastic tape to the medial dorsal surface of the wrist and continue in a medial to lateral direction around the wrist to the MCP joint of the thumb with moderate roll tension. Next, cross the MCP joint, encircle the thumb, and anchor on the dorsal surface of the wrist with moderate roll tension. Slightly adduct and flex the thumb while applying the anchor dorsally. Apply 2 to 3 strips of 1-inch non-elastic or elastic tape in the medial to lateral pattern with moderate roll tension, overlapping each by 1/4 to 1/3 of the tape width in a proximal direction on the thumb. The tape strips should remain proximal to the interphalangeal joint of the thumb. The strips may be applied in an individual or continuous figure of 8 pattern around the thumb and wrist. Anchor the strips with moderate roll tension around the wrist using 1-inch or 1.5-inch non-elastic tape applied in a circular pattern.
So it's definitely a great technique for the thumb, but you can also bandage really any limb, because spica means well, actually, I don't know what the actual Latin term means, but it's bandaging that is applied in that successive V-shaped crossing and is used to immobilize a limb to the trunk, to the body. So you really could do it to any limb. You can do it at the shoulder and the hip. So I've seen it at the hip.
The basic thumb.
All right, so this is Amy. And she's going to, she's going to do the 2 different applications for the Una boot.
We're going to go over the application of an Una boot, which is the standard of care for compression therapy. So I'm going to have you bring your leg on down. And Una boot was named after its founder who developed it, was a Dr. Una. So it's actually called Una's boot. This is a gauze wrap that's impregnated with zinc, and it's actually a real soothing okay, so you make sure that you have your foot at a 90-degree angle, and when wrapping you have the Una boot folding, coming out underneath, not above, because you'll cause too much tension above. And oh, it's cold. Yeah, it is. But it feels, when you have heat on your leg or anything like that, it feels very, very comfortable. You lock it in place and you start right at the base of the toes, making sure you don't have any wrinkles in it. And anytime you're going over a joint, it's best practice to go in a figure 8 like a racetrack, because it allows the joint to bend. You make sure that you cover the wrap before by about half or 50% and just wrap up on the leg. Not too tightly. Don't be concerned about anything extra here, because we'll take care of that once we hit the top. We're going to continue wrapping till we are right at the base of the patella. And at that point, I'm going to cut it. When you're applying an Una boot, you want to make sure that you have as least wrinkles in it as possible. And the best way to do that is to make a quick snip, and you can smooth out. Reason behind that is you do not want to have any additional pressure spots. And here it's kind of tight, so I will go ahead and do a quick little nip, so as the Una boot dries, it will not cause any undue tension on the skin. And I'll just smooth it out. This is the medication part of the compression therapy. Next, we will apply the compression to it. Important to note that with compression, where you want the most compression to be is from here, the midfoot, coming up around the ankle. So we're going to lock it in place. Come up the leg, making sure that you go into and cover the ankle as well as the heel. There are two methods of wrapping an Una boot. I like to wrap what's known as the herringbone, where I do a figure eight going all the way up. We'll show you that method, and then I'll show you the standard. I like the herringbone just because of the fact it applies a better compression and an even compression. One thing to remember when wrapping with the Coban is if you start to run out of Coban, please do not super stretch. Go ahead and open up another pack. Once you reach the top, you're going to go ahead and just wrap and secure around. And that's the application of an Una boot with the herringbone.
Ta-da! So, sorry about that. I was using this little device that followed her face. So every time she moved her face, that little thing would move with it to find her. So the second application of the Una boot, so the under layer just remained on. She just took off no, sorry. She cut the whole thing off and reapplied the dressing that was impregnated with the zinc. Which felt really cool. And I, if you have a swollen and a hot area, that Una boot would have felt amazing. So this is just the different, instead of the herringbone application, this is more circular.
This is just the standardized wrap of the Una boot when you are not using the herringbone pattern. The Una boot itself is applied the same way. Compression is still, the most of it's going to be from the midfoot up above the ankle. Include the heel. And you just go on up, wrapping, covering half of the previous strip. This is much like if you were casting someone. It's important to remember, never apply too much tension. You want to apply just the right amount. And once again, don't overstretch. Make sure that you give yourself enough Coban to make it around and secure in place.
Great. So this does not feel tight at all. It feels comfortable.
Does it? Good.
And Amy, what's the difference between the way that you wrapped it? It seems very similar.
It is similar, except for the fact the second wrap was how most everyone does, and it's just a standardized wrap like you'd put a cast on. I just don't like I feel you get better compression and helping the blood flow up when you do the herringbone.
The first one.
Because it's wrapped like this. And in order to take these off, you start at the top, cut down. Remember, if you have any wounds, to mark it out here so you don't cut into the wound. Also remember that you have little landmarks like your ankle bone, and you certainly don't want to cut that.
What is the medication on this?
It is zinc.
Zinc. That's it?
Zinc and calamine lotion.
Wow.
Yeah.
Feels nice.
Just nice. There you go. And it just warmed up,
Yeah.
which is an exothermic reaction.
So I do think that the hardest thing about this kind of use of Coban is to know how much tension to use. And there's not really any specific guidelines. It's one of those things where you just have to practice with it and constantly assess your patient. Because even in the 3M how to use Coban guidelines, there's really not any specific rules as far as how much tension to use, because you control the tension and the compression, and it's based on each individual patient. But I did find a really interesting PDF file, and I can email that to you all if you feel like you need it. That talks about different guidelines for using Coban and some different wrapping techniques. The Una boot did feel really nice. And there wasn't any, I didn't feel like there was a lot of compression when she put it on me. Even with, because after the first one I stood up a little bit to get the camera. So I felt like I had full mobility, and there wasn't really any tension, especially at my ankle, which is where I expected it.
This is just the standardized wrap up.
Now this is a different application of Una boot, and there's some before and after pictures of the healing process that took place. So this one's also really interesting. You see how the wound changes with with several applications actually of the Una boot.
Hey, this is Dr. Newhouse. I got another video for you. This is a patient who has what we call a venous stasis ulceration. It's a wound that's due to poor circulation, actually with the veins. In this situation, the lady came from actually another country and has this wound, has had it for several years, had treatment there, which was just basic wound care, putting creams and such on it. What I'm going to do today is use a bandage. This is actually called Fibricol that I'm putting on. You can see that I tear it. It's like a foam dressing that absorbs a lot of drainage. These wounds tend to drain a lot. So what I'll do is I'll put this on there to help absorb the drainage, and then we wrap it with what's called an Una boot. An Una boot is nothing more than basically a gauze wrap with zinc oxide, kind of the same stuff you'd use for a sunburn or to prevent a sunburn.
Just want to point out that look at her shoes and look at this other ankle. Like that's another, I think, ulceration waiting to happen, or she probably needs a lot of foot care. That looks very suspicious on this side.
Comes in a roll, rolls on very easily. You have to control the swelling. That's really the trick with a venous stasis ulceration like this, is to control the swelling. So people that have this problem, you can see the leg's very swollen, it's red, it drains a lot. By wrapping it with the Una boot, you compress that and get the fluid out of it, squishing the fluid up the leg. Most people will wear this for anywhere from, I typically tell them 3 to 5 days, depending on the severity of the problem. In this case, because this is very large, it needs to be changed every 2 or 3 days. I was changing this in the office, and this wound has actually gone on to heal very nicely. Shrinking up a little bit every day. You can see the wrap goes on very easy. It is very moist. It does not dry up like a normal cast would, though I do call it a cast. We put some extra gauze on over the top because it's real wet and can make a mess on the floor or in your shoe. It's not going to harden up. It's going to stay flexible, but it certainly does minimize the motion across the area. And the biggest thing is it controls the swelling. So after we put the wrap on, this patient will be instructed to wear a surgical shoe and just limit her activity, but she can go ahead and do whatever she wants. The downside to these is you do have to keep it dry. So you got to cover this with a bag of some sort if you're going to bathe. If you get it wet, you cannot take it off and put it back on like you could an ace wrap or something like that. I secure the outside with a wrap called Coban. The Coban is real stretchy, also a little bit compressive, and adds a good layer of compression to help, again, to control the swelling. We control the swelling. That allows the body to heal up the wound, and people do great with a problem like this. A wound of this size, which is about 8 or 10 centimeters, will take a few weeks to heal. Several treatments like this, but as I said, we're able to get a wound like this to heal up without a lot of difficulty. So I hope you can see from the pictures here the progress that we make between the before treatment picture and the weekly pictures that we've taken, that treatment for a venous stasis ulceration with an Una boot can be very, very successful.
All right. Okay. Wow. Well, I'm sorry I'm a little short on content. Let me just start my video. Stop sharing. Okay. So I have another poll question for you. Let's see this. Okay, here comes the poll. Okay, you should see it now. I kind of like choice 3, actually. I do love telling, new students, especially in medical terminology, when you're charting things and you have a wound that has exudate and it has pus that is coming out. You never want to use the term pussy. You don't ever want to put that in a chart because you are going to spell it wrong. You need to use purulent. Okay. Right, Emily? It only takes one instance where where you chart that you're like, oh, I wish I hadn't hit save on the EMR. All right, so I'm going to end that and share. Now, yeah, actually, CMS does stand for Center for Medicare and Medicaid Services, but in this instance, it's circulation, motion, and sensation. So. Emily, I'm sure, yes. Okay, close the poll. All right. So I did want to update everybody on the close that certifications. So I do have certifications for attendance. If it's okay with you, unless you need them immediately, since a lot of you are doing all 3 sessions, if I could email all 3 certificates at the end, after Richard's presentation in December, and then I can send you all 3 certifications. If you need something in the interim, you just let me know, because I sent somebody one that needed it right away, and it kind of prompted me to make them all. So I do have them all made. So if you need the certificate of attendance or completion before Richard's presentation in December, you can just let me know. Otherwise, I'll send them all at one time, all in one email. The other thing is, I heard from the person who does all of our, I guess, credentialing. So she helps me get the AAMA approval. Bonnie Bruntz from the Colorado Society. So I emailed her the roster from the last session a couple of days after we were done. So she has it, but she's been working on something else, so she hasn't actually submitted it. So I want to make sure that everybody knows that it's going to take maybe another week before that information goes to the AAMA and before it appears on your kind of like your transcript on the AAMA website. So just want to let you know that she has to do it. I can't do it, which it would have been immediate if I was able to do it, but it has to go through Bonnie first. Okay. Well, are there any other questions or comments? I do see some video editing that I need to play with, but otherwise I am so used to doing the wound care session face to face, and then you can practice with the Coban, and there's usually a little hands-on portion to this presentation. So maybe sometime in the near future we'll be able to be face to face again, but this works in the interim. So
I have a question. Oh, sorry to interrupt.
Go ahead.
What day is the December one? Because my Saturday that I usually work got switched around.
It is December 12th.
Okay, so if I want to sign up for that one, I can just email you?
Yes.
Okay, thank you.
You're welcome. And Richard, are you here?
Yeah, I'm here. Hi, guys.
So Richard's session is in December.
Hi.
Do you want to talk about your session, Richard, just a little bit?
Sure, why not? Hello, everybody. Usually I'm wearing a collared shirt, but it's Saturday. You know, hey, what can you do, right? But looking forward to see everyone coming up, what, in like 4 weeks or so. I'll be talking about some geriatric aspects of medical assisting. So primarily working with older people. So looking forward to presenting that to you folks, and we're gonna have some fun.
Awesome. Yeah, it'll be a good session as usual. And we are still, you know, we're thinking that this is probably going to be a process that we will continue with the Zoom offering for continuing education until things drastically change or vaccine miraculously takes care of this. So any other ideas for topics, and gosh, even guest speakers would be amazing. So you just let me know. Otherwise, I'll be in touch when I send out the Zoom invitation for Richard's sessions for December. Any other questions?
Carrie, you said you already have from for January, February, and March.
Yes.
Did you send it already? Did I miss it, or is not out yet?
No, I haven't sent that particular invitation yet. I was waiting until I'll probably send it out closer to Richard's session.
Okay.
And that way we can solidify dates and make sure that the individuals who offered to speak are still available for the times they said. So January is going to be the transgender helping transgender patients. And February is going to be the female genital mutilation and cutting topic. And then in March, it will be sex trafficking. So all really kind of heavy topics. But
Picking
yeah,
some
I will.
good ones for the morning.
I know the wound care one, gosh, when I was putting it together, it was kind of hard for me, still hard for me to see all of those those wounds. This is definitely great for dieting.
Yeah, I walked in, or my sister had walked into my room to ask me a quick question, and one of the wounds was popped up, and she goes, "Oh, never mind," and walks away.
All right, a hard pass on that. All right, well, I'm going to let you all go. I hope you have an amazing Saturday, and I'll be in touch. Again, email me if you need a certificate before December for this session, and I'll see you in a month or so.
See you next month.
Yes, lovely.
Bye-bye, everyone.
Bye. Thank you so much.
Have a good weekend.
Thank you.
Bye.
Bye.
Thank you, Carrie.
Thank you, Carrie. Have a nice
Oh, yeah,
day,
you're
guys.
welcome. You're welcome, welcome.
Hey, Carrie, how's it going?
Good, how are you?
Hey, good. Hey, I tried to send you that
Let me stop recording.